Morning. So, this was the session we took 2 Saturdays ago, heterogeneity of treatment effects. So, I'm going to take the part two of this, but I think some of you might have missed the part one. So, I'm going to uh, just have two slides on part one and then I'll switch to part two. If you remember this, imagine you living in one universe, you're not well, you take treatment A, and you living in a parallel universe, you take treatment B, then we can say that, oh, treatment A is better than B because everything else being same, A is better than B. But we know that everything else is not the same. Even if they're identical twins, they may not be living in the same place and the same environment and same risk factors. So that's called the parallel universe problem. So these are the resources which I would urge people to read, the path statement and this particular article from Lancet 2025 by Elizabeth Munro and colleagues. I will skip quickly to something which we did last week, just as a reminder to people. This one. Imagine a randomized control study. You have a group of people who have inclusion criteria. You don't know that they look different. You think they all look similar to you. Some are given treatment A and some B by randomization. And at the end of the study, the treatment is not found to be beneficial. So you say that treatment A is equal to B. This is called the average treatment effect. That's what we even versus trial. All these are called the average treatment effect. Then we say that, oh, okay, maybe that there's something more to this. This group of people will put into a model like Mercy's model, which she showed, and we'll say, okay, are there three different groups of people in this one single randomized control trial? So that model will be derived in one particular group of patients in one database. Once you get a model, you have to validate the model in a subsequent database. So model development has two parts. Then we come to what is called individual treatment effects. So we'll say that the model says that there are three types of people: purple, orange, and green. The people in purple, A seems to work better than B. People in yellow, A is as good as B. And people in green, B is better than A. So now we have got what is called individual treatment effects. So how do we proceed with this? Again, this is a recap, so I'm going to go a bit faster than last time. So what we do is when a patient enters the hospital, we don't know the color. The color is based on his age, gender, comorbidities, or whatever risk factors he has, and that data is put into a computer, the model, and the model will turn out for the clinician that this patient is either A or B or C, and it will tell the model, the computer. This is called the clinical decision support system (CDS). That will tell the clinician this person is an A. He's given is purple, given treatment A. So this is the ultimate effect of having an individualized treatment effect. So this is the goal, though it's not very commonly available. This is why we are taking the class on heterogeneity of treatment effects. So that was for those interested. The video is up online from last 2 weeks ago on heterogeneity of treatment effects. So I apologize for jumping many slides very quickly now. So I'm going to start part two today. This is the part two of what we did last week. So part two begins with just a reminder. These are what people think a randomized control study looks like. All human beings. And the treatment effect is called average treatment effect. We think that everybody in the clinical trial or cohort study will respond the same as everybody else. But in fact, human beings are some older, some have lower renal function, and some are smokers, some are non-smokers. You can see that human beings are quite different from each other. So the treatment effect, what we think is average, is actually an average of some people it works better, some people it works worse, and some people it has some sort of an average effect. So this average treatment effect is actually a average of many different types of people. So what are the other possible extraneous factors? Some people says I'm sleepy, I don't want to take the tablet today. Some people says the doctor says this drug is very good for you. There's a placebo effect. I say, so I must feel happy. Many people say CMC methods is very good. Some more people got the idea. The moment you take the metazine, people goes away a few seconds later. Or the pharmacist says drug is not available, or you have to pay a lot of money for this drug. Patient doesn't have money. Or lastly, the patient is on many other medications which will interact with the drugs. It may actually increase the effect or decrease the effect. So one could say that this is the average treatment effect, an ideal circumstance. This is the placebo effect. So some people actually do better than the average. And these are people with either low adherence or comorbidities or co-intervention to reduce the effect. So that's the effect of heterogeneous treatment effect. So you must understand that everybody using this is the new wonder drug will not respond as well as you think. Some will respond better, some will be responding actually worse than what you think. So this is an example I want to give. This is some people who had lymphoma. There's an early treatment for rituximab versus watchful waiting. So 183 people got watchful waiting, 82 rituximab induction, and 190 got rituximab maintenance. So it's a three-arm trial. So you can look at this. No new treatment is a good thing. That means they're doing well. People with rituximab maintenance seem to do better than people with induction who did worse, and the worst group was watchful waiting. So now we can look at the subgroups. Is everybody responding the same way? You can see that this is favoring rituximab maintenance. This is favoring watchful waiting. And you can see people above the age of 70, it seems to not have any benefit because the confidence interval is plus 1. But in women, it seems to have a great effect compared to men. So this is called a conventional subgroup analysis. One variable at a time subgroup analysis. That's what the previous slide was. Age, gender, beta 2 microglobulin, HP, stage of disease, grade, Lippi score, overall. So this is one variable at a time is called subgroup analysis. So the treatment effects between subgroups defined on a single baseline characteristics, your age or your gender. So the hypothesis is that if you're more than 70, you will not respond very well. Or it could, so this is an inefficient way because it could substantially underestimate heterogeneous treatment effects. So we're looking at one by one. The heterogeneity is actually lost. You're looking at only one variable at a time. So what happens if people fit multiple subgroups simultaneously? So remember that there's benefit for women, harm for older. I told you, about 70 was harmful. Women don't seem to do better. Now what happens if an older woman is there? She's old, so she'll do badly. She's a woman, she'll do better. So are you going to treat or not treat based on this subgroup analysis? So to overcome this particular problem, there is a new tool. Everything in CU is about a tool nowadays. It's called Iceman tool. Instrument to assess the credibility effect of modification analysis. I mean, it's a mouthful. Everybody likes to make mnemonics, so somehow they made a big thing. So what is this Iceman? This is the article of ICE. It comes from this particular journal in, I think, Canadian Medical Academy Journal, CMAG, and it's got this Iceman. The first one is the direction of effect modification currently hypothesized a priori. A priori means before the study into hypothesize that older people will do worse than younger people. Then it's a worthwhile thing. If you hypothesize that women will do better than men for some biological reason, then it's a good subgroup analysis. Second, is there prior evidence? Meaning, is there previous studies to show that older people do worse than younger people? Test for interaction. So I think we did last time interaction test. There's a p-value for interaction. Some people will not put 0.05, they put 0.1 as p-value for interaction test. Have they done thousands of subgroups? We all know that if you go on a fishing expedition, you'll find a fish fighting. So like that, if you do hundreds of subgroup analysis, you will find some of them are significant. In fact, if you do 20 subgroups, by rule 1 by 20 is 0.05. So you will get by chance one subgroup coming significant. If there are only few subgroups which are based on some prior thought, that gives you much more weightage. Now, remember that age is a continuous variable. What have they done? They cut it off at 70. What is the logic of saying 70? You just say 69 is different from 71. That's highly unlikely. So when they make cutoffs of continuous values, be a bit suspicious. Were there any other additional considerations that might increase or decrease credibility? So whenever we see subgroup analysis in randomized controlled trials, you don't have to remember Eichmann and all, but just have the general idea that it must make some sense to you. Otherwise, people are just doing some subgroup to make something of it. Especially somebody may say drug trial, drug didn't work, A is equal to B. I spent PPK $1 billion on every new drug trial or in the overall process. Now let me actually salvage something by finding a subgroup in which I can sell it. Are they doing that, or they genuinely looking for a subgroup in which the effects may be better than some other group? So now we move to another one, data-derived subgroup analysis. This is one of my favorite cartoonists, Mario Miranda. It's an older guy, used to publish in the Times of India. These are the different types of people of India. Right? So to overcome the limitation of subgroups, why not we take multiple baseline characteristics and divide people instead of just age or gender? Can we combine many things together and make groups of people? That statistical technique in machine learning is called unsupervised clustering. So groups of people based on combinations of baseline characteristics. If you take age, gender, comorbidities together and make a single combination and make them as high risk, moderate risk, and low risk kind of event. Now, these include biomarkers. Suppose you have CRP values or you have calprotectin value. You can include that also in the model. These subgroups, data-derived subgroups, is hypothesis driven. You can't say this is clearly going to differentiate you. You're learning from the data. Okay, so the required replication means other people must see the same subgroups work. So it estimates some treatment effects for groups of patients rather than individuals. So it's, I can't say that Ashwin will respond. No, it's a group of people who all have some age, gender, and comorbid characteristics. Together they will respond. Those are groups of individuals. So we can't do individual treatment effect based on this and say that you will respond like this. A group of persons. Within some subgroups, there may be some heterogeneity. Because I said everybody is divided into high and low risk. But within that high and low risk, there may be subgroups of people present still. So one important thing of this unsupervised clustering algorithm is we don't take the treatment assignment where you assign to intervention or control. So we're making these subgroups before, we should not take into account also whether they were in the intervention arm or control arm. That is not taken into account when you do this. So this might limit the detection of heterogeneous treatment effects. So we should not take this treatment effect assignment into consideration. The main advantage of this is you can identify clusters of patients. You can say this is one cluster of patients, this is medium cluster, this is low cluster, this is very low cluster of patients. So they are biologically similar. So for some reason, this group of patients is biologically similar. This group of patients is biologically similar. This group of patients are biologically similar. But it's independent of treatment response. So we don't include the treatment or the response. So if you divide people into groups like this, later on people will ask, hey, what is the biological similarity of these people? So we can look at some, understand deeper biology. Somebody will do basic science research to say, why this group of patients behave similarly. So for future research, this kind of clustering algorithms are very good. So this is a picture of the night sky, and you can see there are many clusters of stars which are called galaxies. So similarly, we cluster patients, right? So once the groupings are confirmed as various clusters, like you can see these stars, they are treated as pre-specified subgroups. So for the heterogeneity analysis, you can stratify patients based on these subgroups, mild, moderate, or severe, or whatever subgroups in clinical trials. So for example, I was working on covering all subphenotypes of ARDS. There's a hypoinflammatory, hyperinflammatory, different types of sepsis. If you have subgroups, then you can see how the treatment works on the different subgroups. The next one is called a risk-based. The next one is called a risk-based analysis. Sorry. The next one is called a risk-based analysis. So we use prognostic models to predict the patient's baseline risk of an outcome estimate on treatment. So the predicted risk, I think people may be familiar with this score, Apache score. It's already readily available. One need not take a trial and make a new grouping and say these are the mild, moderate, or high based on the trial data. You already have off the shelf readily made scoring system. Acute physiology and chronic health evaluation. So if you develop a new scoring system based from an RCT, it is susceptible to what's called overfitting. Because your own model will work very well on your own data. Because why? You derive the model from your data. So you say, I have made a great model. But on a new set of patients, your model may not work so well. So be careful of saying that my model is very great. That's why it's called derivation cohort, then validation cohort. So you need two cohorts to make this scoring system. Second problem, if you do a score risk-based analysis from RCT, most RCTs are small sample sizes. So you will not be able to make a very good scoring system from a randomized control study. For those of you who are interested in this thing, there are two good references. One of them I'll strongly recommend. It's called Tripod. How to make a risk prediction model for patient tripod scoring system. Now, scoring the tripod method. Potential advantages of risk-based analysis. So we can incorporate multiple characteristics to generate a single effect modifier of predicted risk. So for example, you may say that in my randomized control study, people with Apache score high will be stratified in randomization. So there are equal number of people with moderate Apache score, low Apache score, moderate Apache score, and high Apache score. So I have stratified the groups into three, and I can see the subgroup effect, or I'll at least make sure baseline all people have equal number of sickness in the two groups. So that's one advantage of doing this thing. So the other risk-based advantage is distribution of risk in clinical trial. So if you take many randomized control studies, will do critical affairs will be fine. They will exclude anybody with risk of death in the next 1 year. People who are homeless, IV drug abusers, alcoholics, people with multiple comorbidities, those whom the doctor does not want to recruit. So in the end, you're excluding all very sick patients and you take only medium risk or low risk patients. So that the drug doesn't have any side effects, not many people die. So that's very good for the company doing the trial. But it's not very good for us because when the high risk patients you think will benefit more. If you're really sick, you may benefit more from a therapy. If you're not very sick, you may not benefit. You may get better anyway. So that's the problem with putting a lot of low risk patients. You'll have less out. So less potential to benefit from a treatment than high risk patients. So if you do risk-based analysis, you may say that I will take more high-risk patients for my trial because they may benefit more from the study intervention, right? So this is an advantage of the risk-based analysis. What's the problem? There may be no relationship between the risk and the outcome. We are thinking that the risk-based assessment is going to give a correct assessment. Low risk may not benefit, medium risk more benefit, high risk highest benefit. But we can't make up our mind like that. So, for example, a younger person with leukemia may actually be much more sicker but have a low risk score. And the older person with multiple comorbidities may have a high risk score but actually may do not so badly because leukemia really skews the thing. So, a different probability of response to the treatment, though the overall Apache score is the same. Apache score, for example, is acute physiology. Chronic health, if a leukemia, lymphoma, cancer, CLD, the score becomes high. So this, even if you use a risk-based score, there may be populations within that, the same score but different actual risk. So don't blindly follow the risk-based scores. So then it's another complicated relationship. I mean, I must admit that I like AI images, so I liberally use AI images. So what is complicated? Now, if you're previously healthy and you have septic shock, you have a high predicted risk of mortality. Whereas an elderly person with less severe sepsis, more likely to respond to specific therapy, such as immune modulator. But the previously healthy person with refractory shock may get a lower Apache score than an elderly person with less severe sepsis. So there are some problems with blindly following a score and saying that you're going to do well and you're going to do badly. It's complicated. So This one publication which says larger treatment effect in patients at high risk of poor outcome. I told you, no. If you're very sick, you should do better. You have more chance to benefit. So one publication says that the sicker you are, the more benefit. Another publication says larger treatment effects in patients at lower risk of poor outcome. This is completely ulta to what I said. That publication is also available. And another publication says no difference in treatment across baseline risk for the same kind of critical illness. So it's not so simple to just say that yes, I understood. Your high risk will benefit more. Some people will disagree violently. The next one is called effect-based analysis. Effect-based analysis. So the model treatment for an individual patient. At the end of the day, we want to measure precision medicine. So listen online, Dr. Niven has taken a critical appraisal of precision. Precision medicine means for me, my age, my gender, me, my situation, how will this treatment work? So the statistical technique is called machine learning methods, which is quite vast. So the association between multiple baseline characteristics and the difference in outcomes between treatment groups for an individual. ITE stands for individual treatment effect. Okay. So this is just a picture of an elderly gentleman. So it accounts for the interaction between multiple variables. He may be old, he's male, he may or may not have comorbidities. So it takes the account of all these comorbidities. All of these could influence the effect of treatment, age, frailty, vice versa. You may be frail and young, you may be old and not frail. It takes into account all these factors when telling you whether the treatment will likely to work or not work. So theoretically, more accurate estimates of individual treatment effects than subgroup or risk-based. I told you about subgroup. I also told you about risk-based effects. Now, overfitting is if you take one data set and make a model, you say the model works very well because you developed on that. That's called overfitting. So just be a bit careful when somebody makes a individual treatment effect model and says it works very well. Be careful of this entity called overfitting. So that lot of statistical validation is required. You need large sample sizes. So if you're going to make a score for each individual patient, you need to have a lot of data so that we can predict for a future individual how he or she will do. So you need large sample sizes. So to achieve statistical power, large sample sizes. I'm going to use two stories which I used in part one of this. You remember oxygen. Two large trials comparing liberal oxygen versus conservative oxygen target. So in ICU patients, some people like to have 100% oxygen therapy week. Other people will be diving for 21% oxygen therapy saying oxygen is harmful. How can it, which of these two strategies is correct? There were two trials, pilot trial and ICU ROCs. Pragmatic investigation of optimal oxygen targets and ICU approach randomized trial comparing two oxygen. So two trials were there. So this is the first trial of 2,500 patients pilot study, which is the first study, and ICU rocks the second one of 965 patients. So what they did is when you do this, people get confused what I meant by derivation and validation. You make the scoring set based on one trial or one data, and you try and see if it works on the second data set. Excuse me. So what they have taken is the pilot study for deriving the model and validated the model in the ICU rock study. Both are randomized control studies, but they had the data available for both of these data sets. So they did 6 machine learning algorithms on the pilot data set. And this is a statistical technique, cross validation, and there's a Queenie statistics, which is part of the machine learning algorithm to say if the algorithm is working well or not. Among the 6 machine learning algorithms, they found the R boost is one particular technique which seemed to work the best. I'm just putting these words because increasingly machine learning AI is coming to medicine. And we will get familiar with these words. It should not be like Greek or Latin, what are these words? So this R boost is actually something called from an XG boost implementer of the R learner. So it's a type of XG boost. And XGBoost itself is a tree-based model for decision analysis. Decision analysis is, should I treat somebody, yes or no? Will you survive, yes or no? So it's like you do approaches in medicine. If you have fever, yes, do this. Fever, no, do that. If fever, yes, do this test. Like that. Called decision analysis. So just to go, so the R boost was used on the pilot's data set. And what the model derived from that was applied to the ICU logs. So you derive from one data set, you apply it on the second data set. And they're looking for individualized treatment effects. So the predicted difference in 28-day mortality was the main outcome. And the two question was lower versus higher oxygen targets. Okay. Now this looks like a complicated figure. I'll take you through slowly. Zero effect means no difference in 28-day mortality. Above this means higher oxygen target was good, favoring mortality. Lower than this means the lower oxygen target was good for 28-day mortality. This first line is called the average treatment effect. So how do we interpret that? Point estimates seem to favor higher oxygen. So the confidence interval was crossing. Now the model, which was developed on the pilot data set and then validated on ICU logs, it took into effect mean arterial pressure, heart rate, age, CO2, creat, respiratory rate, so many risk factors it looked at. And finally, it came to predicted 28-day mortality. So you can see that as the model starts to add more and more factors, it is able to differentiate human beings into three groups of people. What are the three groups? One group favoring higher oxygen. That means these people are higher oxygen will improve their mortality. This group, lower oxygen favors mortality. And in this group, it doesn't make a difference what oxygen target, it won't change their mortality. Based on the same thing, you can look at it. The large number of people in gray were those who it didn't favor. And these are the number of people who favored higher oxygen. These are the number of people who favored a lower oxygen target. So this is called individualized treatment effect. So you can predict for an individual what is the likelihood that you are going to benefit from lower or higher oxygen target. This is the same thing shown in a picture. This is, I didn't show you the average treatment effect. The average treatment effect was here. This is a lower third. These people will benefit from a lower oxygen target. These people will not benefit from any oxygen target. And these people benefit from a higher oxygen target. This is also called effect-based modeling for individualized treatment effect. So again, just to summarize, baseline characteristics of pilot study was taken. You derived a model from that. That model best predicted ITE in the derivation cohort. And then you use that to predict individualized treatment effect for each patient in the ICU logs. So did it work well in ICU logs? Yes. It clearly showed that in the ICU logs study, the model derived from pilot worked well, it predicted very well in the subsequent ICU log study. Okay, so this is the same thing I just mentioned again. That whatever you derived in the pilot study has been shown to work out well in the ICU log study. So the first cohort pilot study is called derivation cohort, and the second cohort on which you showed that your model actually worked is called validation cohort. Now, this is a picture. Can anybody think what this picture shows? This is school children in US. They're made to. Some of you may feel like that in your childhood, or you may be doing this to your children. But anyway, so it's called interrogation. See whether they really understand what's going on. So once you make a model, you derive the model in pilot study, we have to interrogate it or validate it on the second cohort. So to understand which baseline characteristic had the greatest influence on ITP. So we know that there's a group of people, let us say this story for the people online, I'm jumping. Based on so many baseline characteristics, We divided them into three groups. Now the next step is to understand, hey, which of these characteristics actually was responsible for majorly contributing to these things. Based on that, can we understand the biology of that? Can we then make new treatments based on that? Can we become a little more smart in our understanding? So we use a statistical technique to divide them into three groups. Once we achieve that, then we try to understand, hey, what is the biology behind these three groupings, right? So that's called interrogation. Okay, maybe the picture is a little inappropriate, interrogating a child. So we are trying to then understand which biological characteristic influence the individualized treatment effect. And then once we understand that, then we can make a new randomized control study based on that single variable. We can stratify people, or we can try to make an intervention for that particular variable. So next one is designing a context, a clinical trial in the context of HTE. HTE just means heterogeneous treatment effects. Ashwin will respond differently from you, from you, from you, from you. So Asha may benefit, Ashwin may not benefit, Nanda may not benefit or may benefit. So we have to think about this as heterogeneous treatment effect. Is it a good thing to have clinical trial heterogeneity? What we're doing in RCT, assuming that a group A baseline is equal to group B, they're all the same. But now we are complicating matters by saying that everybody will not be the same. So it's actually a complication for what we easily understand in a randomized control study. This is a picture called about noise in San Francisco. We're living there, there'll be all sorts of noise going on. So this heterogeneous treatment effect is also called noise. It distracts you, right? So historically, it's a problem for clinical trial design. It's also called the noise. So if the goal is to personalize evidence-based medicine, then you say that heterogeneous treatment effect analysis is good. Previous to this, we said, hey, RCT shows treatment benefit or not. Finished. We don't try to see how much heterogeneity in the effect there was. But if you really want to look at individualized treatment effect, then you welcome HT analysis. Yes, it's really good for me. Let me look at it. So it's generally neglected because we generally focus on all our journal clubs, all our decisions on rounds are based on average treatment effect. If you're diabetic with the nephropathy, start an ACE or ARB because it works for all people. There may be some people who it is harmful, some who it's no benefit, and some who is beneficial. So we're not looking at that. We just prescribe ACE inhibitors for all our diabetics. So what do we do? Now again, these are two approaches for this. One is prospective detection. So when you are doing the randomized control study, we keep looking for heterogeneous treatment effect and modifying your trial. That means as a trial is going on, it's being adapted. You're not starting. Usually randomized control studies, there's a protocol, you strictly follow it till the end. Here's a slight variation. You keep adapting the trial as the trial goes on. The second method is at the end of the study, you do the HT analysis. We did the study as we planned. Now we are going to do HT analysis. I told you the three methods of doing HT analysis. So the next one is biomarkers in HT design. So if you want to predict the future, it's quite a difficult kind of a thing to do. And prediction is also called diviner or divining the future, to foresee, to be inspired by a god. How can we predict the future? Nobody can. That's just a trick. So the biomarkers could be clinical. The heart rate, your blood pressure, temperature, respiratory rate, that's also a clinical biomarker. Physiological or some other biological, your CRP level, your creatinine level, your hemoglobin level. These may be hypothesized to predict differential treatment effects. People with high creat will have worse benefit or will be actually harmed by this drug rather than benefit. So that's the time to predict based on these clinical factors. The patient's baseline risk of an outcome or the predicted individualized treatment effect. So we're trying to see if any of these biomarkers can predict that. Right? Okay. Now the problem is that these biomarkers can have a varying range of values. Your heart rate may be 50, it may be 150, it may be 200, and the effect may not linearly go up. As the heart rate goes up, mortality goes up. So actually 50 may have a worse mortality than somebody at 80. and 150 may be much worse. So it's not like a linear relationship. So it's a bit difficult. So it largely depends on the credential of the proposed biomarker. By credential, I mean that it should be credible. This biomarker has been found in many trials to be useful. So, for example, we are always looking in ICU for antibiotics. Oh, shall we give Procal based antibiotic therapy? Some people swear by it. If the Procal is no antibiotic. Some people say no, it's not very good. I'll do antibiotic regardless. So there's an issue of that. It's not like universally everybody says this is the greatest marker in the world. So that's called credibility of the biomarker. Now there's a nice word called predictive enrichment. So enrichment in schools is now like, if you want all our children must be doing good in drums, guitar, football, abacus, Vedic math. So we like to enrich ourselves. So that's called enrichment. So can we incorporate enrichment in our clinical trial design? So we need to enrich the trial to those who are more likely to respond to an intervention. So that's the whole enrichment. We want to make sure we enroll only people who are more likely to benefit from the treatment. That is the enrichment strategy. So that's an adaptive design where you try to take more people who are likely to benefit from your trial. That's called predictive enrichment. So there may be a very strong biomarker. Based on previous trial data, we know that people with high beta 2 microglobulin will do badly with myeloma, and therefore they must be treated faster than somebody with a low. I'm not saying that is a strong biomarker. I'm just trying to give an example that they may be from previous clinical trial data. So one option is to exclude people. Hey, people with high beta 2 microglobulin are going to do worse. Let me exclude them from my trial. So these options become a bit tricky, like you start wondering, am I playing around, am I doing real good clinical science? So you must be a bit careful about adopting this option of including or excluding based on a biomarker. Unless you're very sure the biomarker is doing exactly what you want it to do. So this is predictive, a very strong biomarker. This is a joke about a weaker biomarker. It says, I'd like to take a no interest loan since I have no interest in paying it back. So it's like, okay, it's nothing is neither here nor there. So the biomarker is not clear about differential treatment response. What do we do? Enroll everybody. In the end, to try to do a subgroup analysis based on the biomarker, people's high calprotectin or low. Was there any difference in the two treatment arms? That's the easiest strategy if you're not very sure about a biomarker. So the randomization, you could be stratified randomization based on the biomarker. And you can do estimates of average treatment effect because you have everybody. And then you can do a subpopulation by biomarker. Is that clear? So there are two ways of doing this. Enhancing trial efficiency. So the word adaptability is known as the capacity to alter your actions or approach necessary to adapt to a dynamic environment. So can we adapt our clinical trial to make it better as we go about? So the second thing I told you, adaptive clinical trials. So we can discontinue enrollment in each biomarker defined spectrum when benefit or futility are confirmed. Futility means all those with low calprotectin antibiotics are not showing any effect, improvement, or benefit or harm, nothing. So halfway through the trial, all those with low calprotectin will be stopped. No future enrollment of patients with low calprotectin or futility. Or we may find all those high calprotectin are benefiting maximally. So we may decide only to include them or to exclude those people and start giving them out of the trial antibiotics straight. This is called an adaptation based on the benefit or the non-benefit of a subgroup. Let me give an example. This is called the Panther trial, Precision Medicine Adaptive Network Platform trial. So these trials where you do adaptive trials are called uh, network platform trials. So, for example, in the UK, in COVID time, they had a large platform trial. Everybody knows the name? Solitaire. So there are many trials like that, where you have 4 or 5 treatments. Halfway through, one arm is not doing well, you stop that arm. Then you take a new arm, new treatment comes available, you add them on. So as the trial goes on, you have arms, people dropping, arms being added, people being dropped out. So these are called adaptive or platform trials. So one example is the Panther trial, which is different phenotypes of ARDS, and you have predictive biomarkers for ARDS and novel therapeutics. So this is the website for the European Respiratory Society Panther trial, and this is the picture they have. So that's one example of a biomarker-based adaptive trial. A second one is called the practical trial, which is being done in the US and Canada. I don't know, maybe only Canada now after all political upheavals. But anyway, it's a similar kind of trial. Sorry, I make irrelevant jokes already. So this is a Bayesian adaptive trial looking at people with ARDS. So we all know ARDS. So what is a Bayesian trial? So you have a belief. High oxygen is good for ARDS. Then you have the evidence from the clinical trial, and you marry your previous belief with the current evidence, and you come to a newer understanding, which is called posterior belief. That is just the 30-second summary of what is Bayesian trial, a Bayesian statistical understanding. So there are 4 groups of patients in ARDS: intubated but require non-invasive ventilation, intubated but have high respiratory elastance. So you can look at the expandability of the lung. Intubated but have low elastance, and people on ECMO or extracorporeal pneumonia. So there are 4 subgroups of patients based on some physiology. There are 4 different treatments: corticosteroid domain, NIV domain, invasive mechanical ventilation, or ECMO domain. So there are 4 large groups of treatment, 4 groups of patients. So you can look at the kind of treatments. Corticosteroid early and extended, very low tidal volume in ARDS through ECMO, invasive ventilation, transitioning invasive ventilation to ECMO, in different types of ventilation strategies, adaptive trials based on, this is for consent. How do you get consent for patients to take part in trials? Nebulized furosemide in patients with ARDS, fludrocortisone in ARDS, mechanical ventilation strategies in patients with ECMO. So you can see you have so many combinations of trial all going on in one single large platform trial. Different subgroups of patients, different subgroups of interventions. There are so many different subgroups going on simultaneously. The next thing I want to talk about is identification of relevant biomarkers during trials. So we may not know that this biomarker is very good before the trial. When the trial starts, we may suddenly identify a new biomarker. So if a range of possible biomarkers are present, we can adapt the design. One is to adapt enrollment. We may decide to exclude somebody. We may decide to include somebody halfway through because this biomarker is good for us. Or we may also adapt randomization. We may stratify the randomization based on the biomarker to make sure that equal number of high Apache and low Apache scores are present. I'm not saying Apache is a biomarker, but whatever biomarker. So this is one example. It's called the I-SPY trial. It's a trial of new adjuvant chemotherapy for people with breast cancer. So it's an adaptive platform trial. I told you about adaptive trials now. So there are 10 molecular subtypes of breast cancer. I thought there were only 3 or 4, based on the hormone status and gene score. So you can divide breast cancer into 10 subgroups. And randomly, they want to assign them up to 5 different treatments. So you can see, you can divide the people itself into 10 subgroups and then 5 different treatments. You can see how many possible combinations are there. So this is currently enrolling, and they expect to stop it in 2031, and they want about 5,000 people. Because if you have different breast cancer genetics and hormone status, each chemotherapy is designed for separately. This is just a snapshot of a different kind of RCTs going on. Pembrolizumab, 4-cycle, whatever this MAP plus irinotecan. So many different combinations of treatments are being trialed on the same platform treatment. So that is called one type of adaptive randomization. The second one is called response adaptive randomization. What is that? Information about treatment response to each treatment in each subtype. As a trial goes on, you know that one subgroup is doing well, one subgroup is not doing so well. Response adaptive randomization, you increasingly give people what appears to be well, you randomize more people to that group. It's also some people call it like playing the winner. Like everybody like looks out in politics also, this guy is likely to win. So it's good to be on his side. Even if I don't agree with his politics, I will tell him, so that it's good for me. I'm just making fun. But it's a similar thing in the randomized trial. Treatment A seems to be doing slightly better. So ethically also it seems nice that us put more people into treatment A than into treatment B. This is called response adaptive randomization. So you're maximizing the probability of reaching a conclusion of a benefit for a given therapy. But you'll have land up with unequal numbers at the end of the trial. You'll have more people in the what you thought is a better arm than in the other arm. So the potential limit is if you have small sample size and you land up with 50 people one arm and 100 in the other arm, you may not have enough power to make any conclusion. So doing response adaptive randomization, you need giant clinical trials. And you must have very available intervention. Suppose you have only one intervention. What is the response adaptation you're going to do? There are only two treatments. Okay, one is placebo, one is treatment. You may put everybody into treatment. So it works well if you have many treatments possible where you can change the treatment allocation. You may also adapt eligibility criteria. You may say that so and so is not eligible anymore. You may also adapt the outcomes. You may say that, let's look at some intermediate outcomes now and add some adaptive outcomes as well. So then it looks very confusing. So actually, when you're going to adaptive design, you must look at your research question carefully. Does this research question lend itself to adaptive randomization or response adaptive randomization? Should I be doing any of this at all? Should I not be doing any of it? It all stems from your question. Sometimes we also like boys' toys. For new trial has come, platform trial. Let us do a study on platform trial. We may not want to do it, but just you want to try out a new thing. That should not be the motivation to do an adaptive trial. Here's an example. Antithrombotic therapy for pneumonia. So during COVID, this was a hot debate. I don't know if you guys, some people swore that people are dying of pulmonary thrombosis. So everybody was on anticoagulation. Another doctor said, no, there's no role for anticoagulation in COVID. So people are still fighting about it. So the initial stage, so this is a particular trial called attack cap trial, and by this okay, I can't pronounce Ryan Zarikansky. At the first stage, treatment effects are estimated, and the basis of combinations of several candidate effect modifiers. So the first stage of the trial, you're looking to see, okay, how is the drug doing it all, and which subgroup of people or which characteristics can identify it will work better. That's the first phase. The second phase, patients with clinical characteristics which are predicting higher probability of benefit, you include only them in the second phase of the trial. And also that first phase, everybody randomized. Half you stop. Hey, who's benefiting more? Who's benefiting less? Can I identify that subgroup? Second half of the trial, only you preferentially recruit people who are more likely to benefit. We also call it enrichment. So enriching the study. So it's also two-stage study design accommodating heterogeneity of treatment effects. So one is you need large trials to do this. All randomized controlled trials estimate average treatment effects. And then within subgroups also you are doing average treatment effect within a subgroup. So the alternative approach is to do information accrued in the RCTs to generate valid models for predicting individualized treatment effects. So if you want to do large trials, what Mercy said today, just before this, It is a registry-based trial. They didn't follow up 100 lakh or 1 crore population and say we are going to follow here. The 1 crore population was in the Danish medical registry. And every 2 years, I suppose, they go for checkups regularly. Every data is recorded in the database. So you can easily do a trial based on registry already available. So many people are now saying let us do randomized controlled trial, registry based. I have an existing group of TB patients in my registry. They come regularly for treatment. In the registry, I do one group of people health mix, suck them out. Another group of people in the DOTS program don't get it. Of course, they are randomized, but the outcomes are recorded by the DOTS provider, by the DOTS team. So the huge number of patients can be easily recorded because they're all in the system, in the registry. And the follow-up is done by the system itself. So this is called registry-based clinical trials. They're also called pragmatic because you can't have fancy outcomes. What are the outcomes? Outcomes that are routinely collected by the DOTS clinic or by anybody else, which we think are clinically useful. So they're the pragmatic trials. And they're representative of everybody because the clinic will have all kinds of patients, not young, not old. It won't exclude sick, non-sick. Granular data means you have good quality data at the bottom, lowermost level. It's not the average age of the people. You have data like for Mercy study. Every single human being's age, gender, when exactly he went to hospital, what drug he took at what day. Of course, we don't know whether he actually consumed the drug which was given. But up to that level, you have granular data. So if you have large pragmatic trials, it facilitates individualized treatment effects. But we need to do rigorous validation. That's an important thing. Now, these large trials are easier for simple drugs. For example, in ICU, should we give 6 liters of fluid a day or 3 liters? Those kind of trials are easily done on a registry-based ICU study because you just have to change a small thing. Or should we give higher oxygen or lower oxygen? Because there are enough ICU patients all over India. You can use a registry-based trial. But if you want to do a biomarker-based study, which is highly specific, and the treatment is only available in few places, it's very costly. Then it becomes very difficult to do biomarker-based studies on a registry-based trial because the costs become very high, right? So that's a balance you have to pay. You want large data sets to individualize treatment effects, but those large data sets are not easy to do on this kind of newer drugs and devices. Now, this threshold is also a bit controversial. Remember, I showed you the picture of 3 groups of people, purple, yellow, and green. We're not 100% be sure. So, and then you're going to deny one treatment, a group of people one treatment. You're going to give a group of patients one treatment. So, some people are a bit scared of that. Are you very sure that this differentiation is so good? So, for example, in medicine, some of us follow this in the OPD, atherosclerosis, American Society of Cardiovascular Disease risk pool. So we all, in OPD, somebody high cholesterol comes. This thing here, that's okay. So we divide patients in the OPD and say, oh, you have high cholesterol, but your cardiovascular risk is low. Because the risk is not only for statin. Another person comes, hey, your cholesterol is high, but your ASCVD risk is high. So we are going to give you statin. So we made a decision based on some previous, what we think is a large randomized control study, which showed that if you divide people based on ASCVD risk, it has a benefit in the end. But actually, in fact, there was no prospective RCT assessing the benefit of ASCVD. It's just this risk score is based on validated risk factors. But prospectively, people have found that it does seem to differentiate people based into high, medium, and low risk of cardiovascular death. Even though there was no RCT, prospectively, people are seeming to find it useful. So we must validate all these things which we do to see whether it really works out well. So, but we are not very sure whether individualized treatment effects improves or not. So really, if suppose I say Andrew has low risk and I don't give him statin, how do I know unless I follow up Andrew and see whether he got cardiovascular risk later on? So it's very difficult to actually prove individualized treatment effects work based on this scoring system unless you do an RCT and have a long-term follow-up. So one is large sample size. The second one is decision tools must be available at bedside. Suppose I have, Srina has some patient's cholesterol level, but has no access to the calculator. We have to go online to do the ASCVD calculator. At that point, internet is not working. Okay, what's the use of having the tool? The tool must be available at the point of care to be accessible. Now, the other challenge is large sample size are required. Trial infrastructure. During COVID, why did the UK suddenly come out with these beautiful studies? They're the first one who said dexamethasone is useful for COVID. And world over, everybody out. Because they had a really good trial infrastructure. All the hospitals already had people trained in clinical trials. The databases were common. They knew how to share data across easily. So, and then they could work together before. So, in India also, we should also have a good network of people who at the drop of a hat we can sit and make a protocol. We can work together, we can collect data. So that kind of clinical trial network is highly required. And harmonization of data between trials. Now, what does SOB mean? I should have like, sir, listen to bad words. Maybe it's hypoglycemia, shortness of breath. But somebody else thinking SOB is a bad word. Harmonization means that if I say BOE means breathlessness on exertion. Everybody will say the same thing. If I quote male as 1 and female as 2, and St. John's Hospital quotes male as 3 and female as 4, then there's no harmonization. You try to join the databases together, they're all quite dissimilar. So we must have this coding of data before. We will be able to easily join databases from different places together. They must be able to talk to each other and easily be harmonized. So if you want to add additional data, it should be easy to add that additional data into a clinical trial. So the last one I'll stop with is called target trials. And I think one of the must you somebody to target trial particular patient? Platform trial. So target trials. Target trial in a simple word is a large observational study. You modify it to look like a randomized control study. It's not a randomized control study. So we have a large amount of data and you rearrange the data to look like a clinical trial. So it's called a target trial. Using observational data, we're doing heterogeneity of treatment analysis. So it's opportunity to benchmark findings from an RCT. In a large observational study, are these RCT data being shown? So it is because the observational study is a large population, we're trying to see is the data from an RCT generalizable in a observational data. Now this is one example. Okay. Now this is the I've taken this from a palliative care journal and looking at palliative care consultation in hepatocellular carcinoma, that is liver cancer, whether palliative care consultation is useful or not. I'm not sure if you heard of the word immortal time bias. So in many cohort studies, there's a problem of immortal time. We only see the person when they enter the cohort, when they came to you first time. And we follow them up to the time of death. But actually, the time of diagnosis was before. So this much time is never taken into account in any cohort study. In an RCT, everybody begins at the same time. In a cohort study, different people have different time here. So this immortal time bias is a particular bias that happens in many observational studies. So what we do in a target trial emulation is, we say that we try to take people at HCC diagnosis, we give them a no consultation time to overcome this immortal time bias, and the time at consultation, time at being censored alive, and you follow up people. If you follow the data for this palliative consultation versus no palliative consultation, if you don't account for this immortal time bias, it looks like neither has a benefit. But if you take into account using this target trial emulation, then it appears that there is some benefit for, and then people with survival probability of these two groups is slightly different. So one of the options, I'm not going to target trials, a big science by itself, but basically you take a group of patients. Say if I did an RCT, I will include only these people. So from a large group of people, you take only that subgroup. They say, okay, what are the two treatments I have taken in the last week? You take only those people with treatment A and B, put them into that. Then you say, I would have excluded these people. So exclude those people in RCT, you would have excluded. When you randomize people, baseline characteristics are equal. So either by doing logistic or linear regression, you get the baseline equal in this observation study. Or there's another statistical technique called you get baseline equal in observational study propensity score. You do propensity score and get two baseline equal. Then you follow up the group of people and you report loss to follow up and you report the outcomes like an RCT. So this is called a target trial. A trial which attempts to make an observation trial to look like a randomized control study. Anybody knows what is phase 4 trials? After the study drug is in the market, actually all of us are supposed to follow up and report to the government of India what happened to my patient. If they benefit, they get harm. Sadly, this is one of those spaces everywhere in the world, phase 4 trials are not done properly, if at all done. So, when you launch a new drug, it's phase 1, then phase 2, phase 3. Discovery phase is here. When you discover a new drug, phase 1, you try on healthy people. Phase 2, only on diseased people who are not very sick. Phase 3 is what we usually do randomized controlled trial, standard of care versus new drug. Post launch, when you deliver the drug to the patients. So, for post marketing surveillance, we may just discover heterogeneity of treatment effects. ACE inhibitors are very good for people who are diabetic with hypertension and it prevents nephropathy. But they found out that black people actually nitrates and hydrazine work better than ACE inhibitors. So we can find out some of these things after the drug is launched in the market. So we can discover heterogeneity of treatment effects. We can even validate it, like a derivation cohort, validation cohort using post-marketing studies. So the only problem is, do you have data from everybody who took the drug? So many people in have taken a drug. Who has got the data of each person who took the drug to have a denominator and then see how many benefited? So the granular data becomes a problem. The advantage, like Mercy said, in Danish countries or Norwegian countries, every single human being, every time they go to hospital is recorded. Every drug they took is recorded. So the system has everything. But we don't have that kind of granular data. So the challenges of this is in a bedside. Remember I told you you're doing the bedside. Clinicians act on individualized treatment effects. In other words, subconsciously when, let us say, Lakshmi is seeing a patient in C ward or A ward, she's subconsciously making a guess. Okay, this patient has fever and cough. He's a little older. I will try antibiotics because I'm not very sure it's bacterial, but I think it's better I be safe and start. So we are subconsciously making individualized treatment effects. We don't realize it, but we're doing that all the time. But in real time, what should happen? Lakshmi must sit in front of computer. This is, and the computer already knows the age, gender, comorbidities. And it turns out, Lakshmi, this patient is group A, antibiotic will work better than no antibiotic. Or no, Lakshmi, this is group C, antibiotics actually harm him. Or group B, in which it makes no difference. In real time, that information must be there and given out. Very few people have got that system in place where today morning's heart rate, blood pressure, temperature, and today's creat, hemoglobin, everything is in the system to generate that information today to make a real-time decision. So that's a big challenge of everybody wants to implement this. Computer will tell. But then the computer must have access to all that information, and you must have access to the computer at the website to give you a real-time information of individualized treatment effects. Okay, we are nearing the end. This is actually the first patent for a car. And you can see that actually this is called the platform of the car or the chassis. And then there's a wheel and then there's an engine somewhere here. It was patented by the Selden in 1895, even before Benz, Carl Benz and others. You know what current car models are called? Anybody an electric car here? So the new car models are called software-defined vehicles. So the car is actually really everything is on a software platform. It's like a mobile phone on wheels. That's what they say in modern cars. It's mostly tech and you have some wheels and an engine. So the modern car looks more like this. There is a vehicle diagnostics, analytics, remote commands, fleet management, and then they have APIs and data collection. This is actually how a car is designed now. You start off with software, and then you said, okay, let me have the chassis, let me have engine, let me have this. So now we call software defined vehicle. So, what will this clinical decision support be? Is it an aid? Is it a device? What do you think, Master? Like as a device, you have a stent. When you get a clearance from a regulatory agency, there'll be legal challenges if you use an unauthorized stent. The stents should have been proven to be used in India. So that's the next challenge. Is a legal or regulatory challenge. So software as a medical device. So the clinical decision support system in some countries is called a medical device because you're going to use it to make critical decisions on sick patients. This person will come to casualty, he is fine, send him home. She goes and dies, and then the doctor will say the system told me, and the hospital will say I got the system from X. So there has to be a regulatory framework for using individualized treatment effects and clinical decision support systems. So then people say now you must do an RCT. Some people have a randomized people to clinical decision support, no clinical decision support, and see whether it made a difference to long-term outcomes. Right. So it's based on complex individual treatment effects models. So in some countries, it is a regulatory issue. Next is the quality of the real-time data. Now I've seen one of our PDs mentioned here, hypertension and diastolic dysfunction. So she says everybody, nobody will have blood pressure measured accurately, and we will do the echo finding for diastolic dysfunction. Most people had 120 by 80 in OPD, and many people didn't have it. I'm making fun. So actually, we tend to round off blood pressure to the nearest 10, right? And then it's magically how so many people are 110 by 80 or 120 by 80. So this real-time data, if you want to make intense decisions, below 90 is hypotension. But rarely nobody, you may find 89 by 79, but we tend to put it as 89 becomes 90. So this quality of the real-time data becomes an issue when you're doing this clinical decision support. So you need good quality of real-time data. Because based on the real-time data, you're making real-time decisions. So some data may come from your smartphone, some data may come from a wired ECG, some data comes from somewhere else. So all this has to be processed by the clinical decision support system and put together. Okay, so let us say that NGAL is a new biomarker. And then I think Anna did a study on NGAL and sepsis, and she says NGAL is very good. NGAL is not routinely available. So they make a complex decision support system and say NGAL will be added to Apache score. 90% of people don't have NGAL value. Then the score is not generated, and you're stuck without making decisions. So these complex new biomarkers have to be readily available in real time to help you to make a decision. The last thing, which I think is very important, which Mercy mentioned also, your baseline heart rate will be quite different from the heart rate tomorrow. Your baseline respiratory rate will be different from tomorrow. Let us say Lenita makes a decision that day one, patient is respiratory rate 40. Oh, he needs to be in ICU. But on the day two, respiratory rate is now 15, and patient looking comfortable. You won't say the prognosis is based on day one. You're constantly upgrading the prognosis. So that's what people say hazard ratios. I think one of the statistics people before this, I'm not sure who it was. One of them, his thesis was on hazard ratios which keep changing. So if you have survived the day two, automatically your hazard is different from the day one hazard. The fact that you survive itself, your chance of surviving becomes more. So they say no, people are 60. The hazard is quite different from the hazard at baseline at zero. If say Indians average mortality, average age of Indians at birth is 60. If somebody survives to 60, he may not die at 61. Because he survived to 60, he actually may live to 80. So this is called a time varying hazard. So if you have a model based on only the baseline, Apache score is the day one age, gender, sodium, potassium, creatine, lactate. But you are constantly evolving over time. Some people may rapidly improve, some people may rapidly worsen. You can't say that they are both same based on the baseline Apache. So this is also very important that we do single time point variables. But illness is dynamic and rapidly evolving. So models which can incorporate time varying covariates. That means your heart rate every day, your respiratory rate every day, your serum lactate every day. Those models may actually work better than models which took only the baseline factors into. So to conclude, we must know about the direction. High respiratory rate clearly makes you bad outcome. But some biomarker will be very clear that the higher the biomarker better, lower the biomarker better. The biomarker must be available, it must be affordable, right? And the patient should be comfortable that he or she is not going to be given a treatment based on the biomarker, or he or she is going to be given treatment. So there's an ethical question whether the patient is comfortable that the doctor is making the decision based on that biomarker. So, for example, if it's a high risk or high cost treatment, for example, extracorporeal carbon dioxide removal is a high risk, high cost treatment. In that situation, you may think, hey, let me see if I can identify a subgroup of people who are likely to benefit and a subgroup of people who won't benefit or it may harm. Then this heterogeneity of treatment effect becomes important. Suppose I want to give paracetamol for headache. We need not do a big HT analysis and subgroup of those who respond because it's a low risk, low cost treatment. Don't waste your time and money in doing HT analysis. Surgical intervention, some complicated pancreatic surgery, acute pancreatitis. The patient is very sick. Operate, you may die, don't operate, you may die. Then HT analysis may tell you, okay, this subgroup of patients will benefit from surgery. This subgroup of patients may actually die from surgery. So their HT analysis may be useful. So, for example, so this is carotid endarterectomy. So we have a lot of strokes in medicine, and many people have carotid artery occlusion. So should we do endarterectomy in everybody? So then there's a scoring system. People whose predictive score is less than 4, there's no difference between surgery and medical. But if your predictive score is more than 4, surgery seems to do much better than medical. Oh, the HT analysis is useful in this particular subgroup of patients. Suppose you suspect in an RCT, which we read, you may not do so many RCT, but with the journal club, we will see. When you suspect HT, first of all, do the routine subgroup analysis. Remember, subgroup analysis, we did test of interactions, we try to understand it. Then, risk-based assessment. Oh, can we classify if the subgroup is good, then you move to the next one. Risk-based is Apache, or already existing risk score. Can you see whether the risk score is really useful or not? Can I use Apache to do that group? And if you are suspecting heterogeneity of the effect still, then we can do ITE based analysis and prospectively incorporate that into our treatment. I'll conclude with where we should be a bit worried. At the end of it, we may say that this new treatment only benefits a small subgroup of people. So to be a bit careful. They may spend a lot of money developing this treatment, and now we're saying that only a small subgroup will benefit. So we may be denying treatment to a large group of people. You must be careful before making that decision. Suppose we say that some particular women are underrepresented in hospitals. Then automatically the women will be less in the HT analysis. So you may exclude women and say that subgroup it won't benefit. Not because they don't benefit, but they are underrepresented in the development and validation cohort. So one needs to be very careful about this underrepresented population. To do such a trial, you need a lot of money, adaptive trials. So that automatically countries which are a little poorer off cannot do adaptive trials, or those patients in those countries may not be able to benefit from that. Suppose you find an adaptive trial which worked very well in US. Will that same adaptation work well in India? Then we have to repeat a trial like that in India, which requires a lot of money. So we'll think a little bit about this HT analysis. LMIC is lower middle income countries. So why would somebody living in a high income country selectively choose poor people for their trial? They take people who are in that country who will not be low and middle income, they tend to be high income people. So automatically many of these HT analysis which are not done in low and middle income countries, there's underrepresentation of people from low and middle income countries. So we are not being represented in that. And that's called inequity. So sometimes people worry that this HT analysis, adaptive trials, adaptive treatments may actually worsen inequity. So many poor people are not allowed to be part of a trial because they were not part of the original trial, or it may not benefit you so you're out of the trial. So you must think about the clinical benefits, resources, and generalizability. So just to put a word of caution before we end, I know it's a bit of an intensive kind of topic, a new kind. It's not new actually, it's there in every specialty we are giving treatments, and we all make some sort of judgment. You know, this lady we had in the ward with low platelets. And then like, okay, shall we give Plex? Okay, you're going to give Plex and cost so much. Will she benefit from Plex? Okay. Then should we now start rituximab or not? Should we give MMF or not? So we're constantly thinking about this. Will this patient benefit? I don't want to mention her name, but will she benefit or not? So we're always making individualized treatment effect. And then there's published data from the West. So we are trying to make these decisions. Right? Make it to a system, clinical decision support system. We're a bit far away from that. But many Western countries, they have clinical decision support married to their EMR. So if you click this, and this, it will give you a differential diagnosis. If you put diabetes, it will tell you the test to be ordered. If you put pneumonia, it will tell you, based on our guidelines, start this antibiotic, do these following tests. In one sense, you feel easy because you are following a system. But we should always be aware you may be doing some harm by doing that. If you blindly follow a Western CDS, we may actually not be doing good. We have to think about that carefully. Okay,